I'm Andrew Morris Singer. I'm a class of 2007 at Harvard Medical School, and originally from New Jersey. Went to college at Williams College in Williamstown, Massachusetts, and trained in internal medicine, primary care at Brigham Women's Hospital in Boston. And currently I'm living in Portland, Oregon, affiliated with the Oregon Health and Science University here. And I'm also on the Harvard Board of Fellows, and I'm the co-director of the Morris Singer Foundation. So I wear a number of different hats, and really excited to talk to you today about physician as advocate. You know, I think of advocacy in sort of this holistic way, trying to make a difference in the world, trying to speak and act on behalf of others, trying to make a difference and work for change, work for reform, you know, leveraging relationships. And so I see physician advocate as really thinking of yourself as a vehicle for change, a vehicle for advancing the views and experiences and needs of others, and how you define those others, how you find those others. You know, there are a lot of different ways of going about that, but I see physician advocate as really seeing yourself as part of something much bigger than you, something that's been ongoing much longer than you've been around, that's going to continue for much longer than you're going to be around. Physician advocate, I think, is seeing yourself as part of a bigger puzzle, and trying to make a difference with both courage and boldness, but also a little bit of humility. It's an orientation, it's a mindset. It's not just there's a person in front of me, which I think medicine prepares you for. The person in front of me, the problem that they're having, this moment, physician as advocate, it's a broader way of looking at the person, what's going on outside of the room that they might not be talking about, that they might not think is possible to address. And you're bringing that in, not just to the room, but to the to consideration to try and do something about. So that's physician advocate. That's my brief answer. It defines what I do. These days for me, physician is in sort of lowercase and advocate is in sort of uppercase, because professionally, the vast majority of what I'm doing these days is in the advocacy realm. And I find a lot of physician advocates at particular moments in their career, that's the case. So I spend most of my time these days focused on advocacy around issues related to professionalism, related to leadership development within you know, health professions, the revitalization of primary care, you know, as a field of delivery, as a field of education and training. And my clinical practice is got a pretty small footprint. But, you know, when I first started my career, it was the opposite. You know, I was a full-time primary care physician, and my advocacy, you know, had a much smaller footprint. And, you know, I allow for the possibility that that could get redistributed a little bit at some point in the future. So I'm doing a number of things. So one of them is really focused on advancing relational leadership in care delivery, in quality improvement efforts, in activities related to addressing clinician burnout, in really teaching people a different way of showing up as, you know, care delivery folks, as team members, as change agents and advocates, really helping people understand what does it mean to have a relational mindset, what are some of the skills and the approaches to doing that sort of work, whether it's quality improvement or traditional advocacy, and supporting people on that journey, and trying to work for policy changes and process, and resource allocation to support that sort of work, and that professional development to enable clinicians to do that. I think a lot of advocates inherently have a relational mindset. I mean, insofar as advocacy is working for change, and insofar as that requires power and resources and developing a coalition, frequently a diverse coalition, you've got to get into relationship with a whole variety of different players. You have to get into relationship with those decision makers who can, quote, give you what you want. You have to understand their interests. You have to understand their perspectives. You have to understand the history of what's happened to date. You also have to understand that with most things in life that we change or we work to change, we don't initially get it right. It's not picture perfect when the policy goes through, the process that we've been advocating for gets advanced. So frequently, we now have entered into a dance with the decision maker, the CEO of the hospital, the elected official, and we have to iterate on the policy, the process, whatever it is. And so if we're not in relationship with that person, if they don't understand where we're coming from, if they don't, if we haven't sort of connected over our shared values and our shared interests, it becomes hard to really achieve the vision that we care about. So we are intentionally relational to be most effective. But my approach has always been relational. It takes longer, and sometimes you don't achieve as much as you would have hoped for. And you have to make compromise. You have to make compromises. But I think it's a much more fulfilling experience. It's easier to stay in it for a longer period of time. And the journey is, it just feels better when you're doing it relationally. So I actually got into advocacy first. I was very involved in LGBT rights work on our college campus in the 90s, and then became a professional community organizer in the LGBT movement before going to medical school. I did that for a number of years, traveling around the country to communities that were facing anti-LGBT ballot measures, training communities and leaders how to work against these, and these were really ugly fights where the opposition, the people that we were facing, were just using really ugly tactics. And so we were in the trenches. We were working, Topeka, Kansas, Tacoma, Washington, Miami-Dade County, Florida in the summer, which is really hot. And just learned a ton about how to be effective, learned a ton about building diverse coalitions, learned a ton about what happens when you lose and how do you come back from it. And really brought that mindset and those, that orientation to medical school. And then realized in medical school that we physicians were being taught a way of being and advocating and being taught about the power that we had as professionals that was quite different from everything that I'd learned and experienced as a grassroots organizer. And so, and it wasn't necessarily one was right, one was wrong. one was good, one was bad. It was just, they were different. And so a lot of my medical school and residency was about trying to meld these two sets of mindsets and skills and approaches together, and really, figuring out what contextual factors made one particular approach to advocacy more effective versus the other. And so that really defined my medical school and residency experience. And, in some ways, I felt like I was hanging up my community organizing, my grassroots organizing gloves in medical school, and taking on a little bit more of what, might be considered traditional physician advocacy. But then in residency, there was a particular moment where we decided to really go hardcore grassroots advocacy. I think it was in the spring of my third year of residency, 2009, where the Division of Primary Care at Harvard Medical School was defunded. And there were a group of us who were really dismayed and decided to use traditional grassroots organizing approaches to try and change that decision. And were very successful. And if you watched what we did, it was very traditional grassroots organizing. It was building large coalitions. It was mobilization of people's stories and numbers to showcase the issue. It was doing a lot of things publicly in large groups. It was applying pressure in the form of media, petition writing, letter campaigns, et cetera. And then working in close collaboration with leaders at the medical school once we had their attention, and ultimately fashioned a new vision for something bold to replace the previous division, and ultimately worked very collaboratively with the dean and the community and funders to create something and then manage it going forward. And that really helped launch our nonprofit Primary Care Progress, which back in 2010 was leveraging the approaches of relational grassroots organizing to help the field of primary care revitalize itself from within, advocate for institutional changes, to support it, to enable it, and really bringing a community together of primary care people to do that work and share those approaches. There have been a few moments for me that they were sort of eureka moments. So it was like this light bulb went off, and it also felt like we achieved something. So, before medical school, going into communities that were facing really nasty anti-LGBT ballot measures and finding that the community of LGBT people was in tatters. People were isolated, they were alienated, they really felt terrified. And the moment that they realized they actually had power, they actually could repel some of these nasty initiatives, and that they weren't alone. And it wasn't just other LGBT people, that there were straight people in the community who were like, yeah, this anti-LGBT stuff is bad. That was incredibly empowering to them, and it was a game changer. It put them on a totally different life trajectory as individuals and as a community. And so the realization that that moment of empowerment could exist not just for LGBT people, but also for primary care people, was a very interesting moment for us in 2009. It might sound strange to say, Harvard Medical School doctors and doctors to be feel disempowered, feel alienated, feel like they don't have agency. That might strike people as like crazy, like, what, this is an incredibly privileged group of people, right? some of the, most highly trained, credible, highly paid. But in actuality, a lot of the people felt some of these ways, and so benefited in a similar manner from some of these experiences, being empowered, connecting with others, realizing that not just primary care people cared about primary care, and realizing they could do something. And once again, that put people as individuals and as a community on a different trajectory. And really, it led to our nonprofit Primary Care Progress launching and developing chapters all over the country. And there was a certain point where we had like 50 chapters around the country, different schools doing similar work. I'd say the second thing is the moment realizing that people that were working with us were having their own realizations that the relational advocacy skills that we were working on together were directly applicable to their clinical work, directly applicable to taking care of patients, working on interdisciplinary teams, working within their own institution to try and reform the place, make it better, make it safer, make it more inclusive, make it more collaborative with the community, et cetera. And that people could lead more integrated lives. So that person who's the physician, and she's engaged with the community in partnership work and community focused work, and has a particular wholesome approach to that feels really good to her and consistent with her values, she can actually show up to work in her clinical care, in her clinic, in how she engages with the CEO and her medical director in a similar relational way. And she doesn't have to be disintegrated, because a lot of physicians feel disintegrated. They feel that how they show up as a parent or how they show up in their community, they can't show up like that at work. They can't tell their story at work. They can't be vulnerable, whatever it is. And so the realization that we can be relational, we can be integrated, and it will not only feel good, but help us do good work, better work. I think that for me has been a particularly exciting and just feel good thing. Around 2009, in the context of some budgetary changes, the Division of Primary Care, which I think was called the Ambulatory Care and Prevention Center, or something like that. I know I'm getting the name wrong. It was cut. And there were a group of students, residents, and early career faculty who were really up in arms about this, and began working behind the scenes at first to understand what had happened and to try and make the case that this department was actually very important, and primary care in general, Harvard and its affiliated hospitals, was really important and under-resourced to date, and really necessitated a lot of investment, not just refunding the division, but doing something bigger and bolder. There was a group of faculty at the time who were meeting behind the scenes with the dean. And there was, like I said, a group of students, residents, and early career faculty who felt that that behind the scenes approach needed to be supplemented by something that felt a little bit more grassroots organizing. And it needed to be public, it needed to be powerful, it needed to be inclusive, it needed to be diverse, it needed to really leverage not just the data about the importance of primary care, but the stories and the passion and the emotions and the voices of the real beautiful team of primary care people. And there were doctors, and there were nurses, and there were social workers, and people working at the hospital level, people working in the outpatient level, people working in the community, just all of it, not just the heads of the divisions of primary care. So we had a series of town halls, we had a letter writing campaign, we had a petition drive. We brought people together on multiple occasions, inviting leadership also to witness and participate and hear and feel the power in the community of health professionals and in the community of patients. We had some patients and community groups participate, probably not as much as we would have liked and should have, but it still was present. And that led to basically the beginning of a dance between the dean and the community and our leadership to reinvent a new vision for primary care at Harvard, which ultimately culminated in a new center for primary care, with the focus being leadership development and innovation in care delivery, that ultimately came into being about a year later and has been in existence for over a decade now and does incredible work, but really came about because of an activated coalition of people that said, we're going to work for something bigger, and we're going to work in a different way to achieve it. And I think our approach was really smart, because whenever you have a center, a new institution or institute, the success of it depends not just on having a good idea and a good strategy, but you have to have engagement. You have to have engagement of the people. And I think we built a coalition of people. We built in engagement and collaboration and a mentality of innovation and leadership, and young people need to be a part of this. And this isn't just about internal medicine, this is about family medicine too. And that coalition then basically inhabited this new center and its programs, et cetera. So I think our strategy was really smart, if I may say so myself. First of all, I think my message to new Harvard students is it's a really exciting time to be in healthcare and health right now. The need is massive. We've all been reminded again, but in a very powerful way, that there's so much more that needs to be done in healthcare and health. The pandemic, I think, made very clear all the gaps that exist that are massive. And for those students who really sort of see themselves as clinician advocates, or advocacy being a piece of what they're going to do, I just say hats off to you. We need you now more than ever. And I'd also say, how you show up as an advocate really matters. In almost every religion, there is the notion that justice must be achieved in just ways is present, that it's not just about the end, that the means you use are really important. And I'm Jewish. In the Talmud, it says justice, justice. And the interpretation of that is, once again, it's not just about achieving justice, but it's about doing it in a just way. And so in your advocacy, you're going to happen upon other people, though, who are incredibly passionate, incredibly well-intentioned, who actually don't necessarily adhere to that, and who believe any means are justified in achieving justice. And I would encourage you to be wary of that. My experience is things you can achieve in the short term are harder to maintain, and you really do damage to your own coalition and to the institutions you're trying to change when you act in ways that are not just. The second thing I would say is, as an advocate, be careful who you define as the sort of opposition, or them, when you're defining us, because you'll frequently find that when you get into relationship with the issue or with the different constituencies, you quickly realize that you actually have a lot more in common with other groups, and you're best able to achieve a win when you get into partnership with those groups, combine resources, combine ideas, Yes, it requires you to negotiate and compromise. And so that takes you away from your vision a little bit, you're right. But it also gives you more power. It gives you more leverage. But you can only do that if you're willing to see other groups and others as potential allies, as potential friends, as potential us. So be careful that how you show up and the language that you're using when you show up to these public spaces to really dive into issues is not just immediately pushing other people away or putting up walls between you and them. Do everything in your power to get rid of walls, to find commonality, to share your stories, to break bread with people and be human with them. Best thing you can do when you're meeting with groups is just eat, right? Break bread with people. It equalizes the playing field. No one can eat without eating in a human way, right? You're having lunch with someone and they get mustard on their shirt. That's a perfect moment where it's like, yep, I'm real. I'm human. And the last thing I'd say is, set your expectations that these institutions we're working to change are massive. They've been around for a long time. There's so much inertia in them. There's so many people who it's just much easier for them to keep things the way they are versus change them. So unless you're going to drive a truck through that institution, which you're obviously not going to do, you've got to be really intentional and thoughtful and methodical and disciplined, and it takes time. And a lot of this work is incredibly bureaucratic. And so, set your expectations, set yourself up for the marathon that, advocacy really is. Yes, the media showcases those amazing quick wins. But most of the history of our country is not those quick wins, but the methodical, sometimes sloggy efforts that achieve change and make make the world a better place and help deliver on the promise of this country. So hang in there. One of the, if not the most important issue to Americans of all political backgrounds, all socioeconomic status, race, ethnicity, gender, is health and healthcare, quality healthcare. That's what all Americans really want, and it's one of the most important things to them. So what that means is the issue that we work on day in, day out, that we are really expert in many ways, not the expert, but have expertise in, is so important to our people. And that puts us as health professionals, and particularly as physicians, in a very unique position to have a very significant impact on the country and the people and what happens in the future. And so it's an opportunity for all of us. It's a responsibility. And if you choose to wear that advocate hat, in addition to being a clinician or researcher, educator, whatever it is, you really have the opportunity to have an outsized role on the future of our country and the future of our people. Hats off to you for considering doing that or doing it, and take it seriously, just as seriously as your clinical work, because it could have just as much impact, if not more.